Hi everyone, my name is Sunny Paniganti. My talk will be about fracture dislocations of the ankle. I'm an intern at Eastern Health Service in Melbourne, Victoria. What is a fracture dislocation of the ankle? Just like the name suggests, it is a dislocation of the ankle joint, also known as the tibio-talar joint, which is most commonly associated with a fracture of one or more bones that make up the ankle. The ankle joint is a hinged joint allowing flexion, extension, inversion, and eversion of the foot. As we can see in the diagram, the ankle is made up of three different bones. The inferior portion consisting of the talus, the medial part made up of the tibia, and the lateral portion made up of the fibula. As seen in the diagram, there are also multiple ligaments that provide stability for the joint. 99% of all ankle dislocations are fracture dislocations. It is more common in males, accounting for 72% of cases. The average age of the patient is 49 years old. The most common causes are sporting injuries in 31% of cases, followed by motor vehicle crashes in 30% of cases. Fracture dislocations of the ankle are exclusively caused by trauma. Almost all ankle dislocations are a result of a fracture. In the diagram we can see some common mechanisms of injury. The most common mechanism is when the foot is supinated and externally rotated. This occurs in almost 60% of cases. Since ankle fractures are caused by trauma, there aren't many risk factors. The main risk factors are high impact and extreme sports that predispose you to having a traumatic event. Also high BMI, which increases the force of the trauma. Finally, risk of falls, usually attributed to old age, intoxication, and poor vision. Interestingly, osteoporosis has not been found to be a risk factor. This means that you do not have to work up patients for bone density after an ankle fracture. So classifications are an important way for us to communicate the injury to other doctors. There isn't any one classification system specifically for fracture dislocations of the ankle. However, you can use a combination of systems to communicate the injury pattern. Firstly, is the fracture open or closed? Secondly, is the fracture isolated to one malleoli, a bimalleolar or trimalleolar? Bimalleolar is the medial and lateral malleolus, while trimalleolar also includes the posterior malleolus. Finally, you can use one of many classification systems to describe what the fracture is. The most popular for ankle fractures is the Weber classification. Weber A is below the level of the ankle joint, B is at the level of the ankle joint, C is above the level of the ankle joint, as we can see in the pictures. So some differential diagnoses are a soft tissue injury such as an ankle sprain or a ligamentous injury. It could also be a fracture of the foot or proximal tibia. It could be an ankle fracture without dislocation. Although uncommon, it could also be an isolated ankle dislocation. So on presentation, the patient will almost always be unable to weight bear and will be complaining of throbbing pain in the ankle. There will also be swelling around the malleoli. There may also be bruising present around the ankle joint. There may also be a gross deformity, which makes it very obvious. When the clinical presentation is unclear, you can use the Ottawa ankle rules to rule out ankle fracture. Looking at the diagram, we can see that if there is no tenderness in the medial and lateral malleolus and the patient can weight bear, then an x-ray may not be necessary. As soon as you know that a patient with ankle dislocation fracture is stable and they're not neurovascularly compromised, x-rays of the affected leg should be obtained. So what x-rays do you need? You need three views of the ankle: an AP view, a lateral view, and a mortise view. A mortise view is an AP x-ray while internally rotating the foot 15 degrees. You should also get an AP and lateral view of the full length of the tibia and fibula to identify any proximal fractures. We'll see some of these later on. If close reduction is performed, you want to repeat the three views of the ankle post-reduction. Finally, CT scans of the ankle can be useful depending on the trauma. However, this should happen after consulting ortho. Here we can see a fracture of the lateral and medial malleolus on the AP view, while the lateral view shows us the posterior malleolus fracture and the posterior dislocation of the talus. The initial management always starts with taking history. You should ask about the mechanism of injury. Was there any prodrome to the injury? Was there any head strike or loss of consciousness? This can give us clues to any pre-existing conditions that caused the fall or any neurological injury post-fall. In terms of examination, firstly you want to check if there's any presence of an open fracture. You want to then check the neurovascular status of the affected limb. The neurology can be tested by checking sensation and motor function of the sciatic nerve. The vascular status can be determined by palpating the posterior tibial and dorsalis pedis pulse, also by checking the capillary refill of the toes. It's also important to make sure that the patient's pain is being well managed and asking the patient when the last meal was in case they need to have surgery. The next step in management is to reduce the dislocation. This can be performed under sedation or with an intra-articular block. Simply put, to reduce the ankle, you want to place the ankle in traction and reverse the mechanism of injury, as seen in the diagram. Then A below-the-knee cast should be applied to maintain the reduction and prevent movement. The leg should also be elevated to reduce swelling. Finally, post-reduction images should be taken to check the alignment of the ankle. Here are some post-reduction images. This can be best appreciated in the lateral view. We can see that the ankle is reduced. We can also see that there's a cast maintaining the reduction in situ. So definitive treatment involves orthopedic surgery. The surgeon will perform an open reduction and internal fixation with screws and plates. However, the timing of surgery will depend on how swollen the ankle is. A swollen ankle makes it more difficult to close the wound post-surgery. So here we can see post-surgical imaging. In the post-surgical x-rays, you can see an open reduction and internal fixation of the 3 malleoli with plates and screws. So some of the long-term consequences of fracture dislocations of the ankle are ankle stiffness, chronic arthritis, neurological or vascular damage, compartment syndrome, dehiscence of the wound, infection post-surgery, malunion of the fracture, irritation from metal wear, and ligament laxity causing future dislocations. Thank you everyone for listening. If you have any questions, please contact me on my email. Thanks.